we are still seeing the majority of cases in Australia related to international travellers returning from the rest of the world. The number of people returning to Australia is now almost entirely Australian citizens and permanent residents, and that is decreasing every day. But we're still having several thousand people per day coming back from these places where the epidemic is much more difficult and many more cases than we have here in Australia. It's almost in every single country in the world now, at least a few cases. So that's the international situation. Nationally, as of just a few minutes ago, 2,793 cases with 12 deaths. Those people that have died, there's been several over the last 24 hours, very sadly, and my best wishes go out to the families of those people, of course. The majority of those deaths remain in older people, although there was a person died overnight who was in their 60s. So this is showing that why we are taking this situation seriously and have done so since the beginning. I just wanted to talk about the issue that we're finding with testing. So we have, as we announced yesterday, increased our testing width, so we're testing more people, more categories of people, but also many more tests. The testing that is available in every state has been expanded over the last few weeks, and now we have tested over 178,000 tests have been done in Australia. About 10,000 a day now is our capacity, and everyone is testing both in the public system and the private system, so there are many possibilities of getting tests. There are new tests that have come on the market, and I just want to really address that. We are not at the stage of people being able to do their own tests at home, a so-called point-of-care test or a rapid test, although there are rapid tests that will be coming into Australia. Indeed, some have already arrived and are undergoing the very important quality, safety and efficacy testing that our Therapeutic Goods Administration does. We are really ramping that up to make it as quick as possible. Several of these tests were rapidly put through that regulatory component over the weekend. But it's very important that we have tests that work and are reliable, and they are the ones that people should be having, and they will have them if they go through the system that has been set up. But 178,000 tests, that's a lot. It's probably more on a per population basis than virtually anywhere else in the world. It is, for example, over 25 times as many on a per capita basis as has happened in the US. In the US at the moment, 53% of those tests are positive, which demonstrates that they have a long way to go to have enough testing being done in the United States. Here our positivity rate is just under 2% now, 1.5%, and that again demonstrates, firstly, that we're doing a lot. Secondly, it convinces me that we're finding the ones that we need to look for. In terms of other things we are ramping up our healthcare worker engagement, and so my colleague Professor Michael Kidd ran a webinar today, and we're committed to doing that every week, at least once a week. There were 14,000 healthcare workers on that webinar. It demonstrates that people are keen for information, but also that there is an opportunity for people to ask questions to be answered by Michael, and that's just one of the ways we're getting that information out from the Department of Health. We are continuing to scour the world for the things that have been talked about over many days, ventilators to put into our intensive care. We are expanding. We're in the midst of expanding our intensive care capacity right now, but including looking to purchase more ventilators both here in Australia and elsewhere. Similarly with personal protective equipment, there has been issues with that over the past few weeks, as has been talked about a lot, but we are increasing our capacity to make masks in Australia, looking for ways that we can increase our capacity in our national stockpile, and then to push out into the frontline services that need these things as soon as possible, and indeed we're doing that right now. We're looking very closely and carefully with the colleges, the medical colleges and other societies, as well as our nurses and midwifery and our allied health workforce, at models of care which can work not only for safety of those staff, but also to give the right care at the right time to everyone that needs it in relation to not only COVID-19, but to all of the other health issues that we continue to face. I just want to make one more absolute key point about what are we trying to achieve here. We're trying to achieve the flattening of the curve, which means having less cases if possible, but certainly having that rise in cases to decrease over the coming weeks. And as we do that, what are the key principles? Social isolation, keeping people apart as much as possible. When you are in situations where there are other people, keeping your distance from those people. And most importantly, if you are sick, stay at home. If you are sick with the symptoms of COVID-19, particularly if you are in the higher risk groups, so that's return travellers, people from age in healthcare professions, people that have been in contact with a known case of COVID-19, and people with pneumonia, which is seems to have no other reason for having that diagnosis. These are the very important areas that should be tested as soon as possible. Stay at home and isolate from others to protect others. This is in our hands. We need to wash our hands, is the other message, of course, but the whole thing is in our hands as a society. We need to take these things seriously, and those messages for return travellers, for those that are sick, those that have been recognised as contacts of people that have COVID-19, we need to stay at home and isolate ourselves from others. I'm happy to take questions, thanks.
Professor Kelly, the Prime Minister announced on television yesterday that all elective surgeries that were not essential were going to be cancelled from midnight, and then reversed that decision at last night's National Cabinet meeting. Did the AHPCC endorse that decision to extend the deadline for private hospitals to April the 1st, and will private hospitals be given increased access to PPE?
So the main understanding, the main issue for the elective surgery decision, which is a difficult one, and we don't want people to be disadvantaged, and that's why urgent cases throughout will of course continue to be done. But this is about conserving PPE. Key messages from our healthcare workers and really for all of us. If our healthcare workers are not able to perform their duties safely in relation to COVID-19, then the healthcare workforce will not be there to help all of us when and if we get sick with this or this issue. So that was part of our strategy to decrease demand for PPE, whilst at the same time, as I mentioned, really ramp up the supply both locally and internationally.
But the National Cabinet has gone against the recommendation of the AHPCC, is that right?
Elective surgery in public hospitals it will be limited, as has previously been announced. The private hospitals will have a bit more time to work through those matters, and
I think the advice of the expert body didn't change.
Well, the advice of the expert body is that we have a shortage of PPE. We need to look at increasing that supply and decreasing demand by whatever way we can do. Another question?
You previously talked about doing an exhaustive look at every available ventilator or what can be potentially changed to Houston Hospital. How long will it take for that capacity to be implemented in hospitals? Will it be staged as products become available? How will that work?
Well, so we are right now in the midst of doubling our ICU capacity. So we're not waiting for what may or may not happen in the future rather. What I said yesterday though holds. There's still the majority of the cases that we have diagnosed so far are relatively minor illness, and the numbers of people that have been admitted into intensive care throughout the entire length of this epidemic, remembering the first cases were back in late January, is still very, very small. so around 1% of the number. So we are definitely planning for an increase in not only ICU utilisation but also throughout the rest of the hospital. Many hospitals are looking at ways that they can increase their capacity in hospitals, or to move capacity into a way of having people that are sick with COVID-19 safely for themselves, for staff of the hospital as well. So the ventilator component of that, of course, is an important component, absolutely, but it's not the only component.
Professor, can I just ask on that ventilator issue? There has been a lot of talk about converting machines to become ventilators, but specialists say that only ICU ventilators are superior enough to treat people who are critically ill from coronavirus. Do you agree with that position?
So there are certainly some people that will get sick with coronavirus that do need the specialised type of ventilators that are in intensive care. It's true, but this isn't just you're well and then you have to have that type of ventilator. There are various ranges of care that need to be done, and in the end, if the only thing we have is the ventilators that might not be the 100% absolute gold standard, but they are effective, they do work, and up to a point can be life-saving, I know what I'd prefer to have if I was sick. Just last one over there, yeah, at the back, yeah.
Sorry, in regards to some of the cases that have been developing, how quickly can the severity of the cases develop? Some of the cases we saw in Melbourne, where someone has died, they weren't in ICU before they progressed to the point where they did pass away.
Yeah, so I obviously won't be commenting on specific cases, but what we've found looking internationally, and it appears at the moment to be similar in Australia, although most of our information still comes from that early outbreak in China, is that people tend to get sick in the second week. So they're sick with symptoms. First week not too bad, second week suddenly get worse. That seems to be a common trait. So the illness can last for quite some time, particularly the most severe ones. Why someone became severe and wasn't in intensive care, I can't comment on that particular matter, but it could have been some specifics in relation to that hospital or indeed that particular person. Yeah, another question.
Thanks, Professor. Just on the Swiss hotel, which has been declared a quarantine zone for people coming off a cruise ship, a resident of the tower apartments above the hotel is upset because they apparently weren't told that this was happening. They're very worried, basically scared to walk out their front door. They share lifts with the hotel, and just wondering if you can give any reassurance to these residents. Are they going to be coming in contact with these potentially infected people in the building?
Yes, so that's a group of people were flown back under a commercial arrangement between Qantas and the cruise liner from a particular cruise ship, the Norwegian Jewel rather, which was docked finally in Honolulu for the last couple of days. What I'd say about that particular group is that they were at sea for about 3 weeks. In fact, they weren't able to dock in many places. No one came on or off that ship. We've seen before and are continuing to see an issue with cruise ships, and so out of an abundance of caution in relation to these particular group, this arrangement was made to declare a quarantine zone in a particular hotel in Sydney, and so you're quite right, that's been done. That particular group, though, really has very low risk of having COVID-19 within that group. There have been some tests that have been done. Those results will be available later today, but so far there's no reason for concern. That is a quarantine zone. Those people are under a quarantine rule. They have been explained that they will be there for 2 weeks, and they will be essentially confined to where they are. In terms of people above or around that, there is no risk from this group to other people at this point.
Professor, last night the National Cabinet, one of the things they agreed to was to come up with a nationally consistent set of guidelines, advice, instructions on self-quarantine for people who are diagnosed with COVID-19. I guess, why wasn't that potentially in place before? What will inform that? Will that be the AHPBC informing the states? And also then, how long can we expect before that is finalised and there'll be some kind of instructions that are standard across the country?
So in terms of instructions, I think it's pretty simple, and I've said, I don't know how many times I've said this. If you're sick, stay at home. If you're in quarantine, you stay at home. If you're in self-isolation, you stay at home. If you are a contact of someone with COVID-19, you stay at home. If you have just come back from overseas in the last 14 days, you stay at home. I don't know how much clearer I can make it, seriously, but in terms of what was discussed at National Cabinet last night, it was really an agreed approach as to how that could be enforced. In several states, that is enforced. And I'll leave it to the states themselves to say how much the fine is and how long you can be put in prison for this, because it's a state-based, state-by-state-based approach. But those rules are in force. In Queensland, from the beginning of this matter, anyone who came back from a high-risk country, when we had a small list of high-risk countries, they were given a public health order, a piece of paper that said, if you don't do this, and it said what you needed to do, essentially stay at home, then there are laws that can be brought into place to enforce this. Other states are now taking it seriously like that as well. There may be further measures if people continue to ignore this. And I must say most people, the vast majority of people, are not ignoring it, and they are taking that advice very seriously, and that's fantastic. That's what we expect from all Australians. Yes.
Placed by the community, and yet hairdressers being asked to continue to do their work, which is well and truly breaching that boundary. What's the health justification for continuing to allow hairdressers to work and for continuing to allow them to be in such close proximity with other people when they don't potentially know who is infectious?
So I'd firstly say no one is being forced to work. For hairdressing, yeah, it's impossible to take those social distancing rules if you can't be that far away from someone if you're doing their hair. But there are things, and there are many things, and I've seen them myself in hairdressers and barbers around town here in Canberra, that can be done very practically. Having hand sanitizer at the door, making sure people wash their hands before they come in, insisting that people that are sick don't come, stay at home. For people that are actually hairdressers themselves, if you are sick with the symptoms of COVID, you stay at home. And then hygiene practices in the actual barbers and hairdressers can of course be improved, and we're really asking people to do that at this time.
Do you see yourself that people can be infectious before they have symptoms? So how could they possibly know? Why should this profession continue right now under these conditions where we're looking at the curve and you're raising all these public health concerns about other industries?
Yes, so no one's being forced to go to work. I'll say that for sure. In terms of the asymptomatic carriage that may lead to people being infected, yes, that is a potentially an issue, but overwhelmingly, and I'm absolutely certain about this, it's people that have the infection and are infectious in those first few days of coughing and sneezing. They are the most infectious people. So if we can't stop this completely unless we all stay at home and the lights go out and no one has anything to eat. So we have to have some sort of sense of what we can and should do there, of minimising as much as possible what can be done to stop the spread. Just one last question.
The crowd says that we should move to a complete lockdown of all but essential services. You've signalled potentially further measures. How many infections do we need to see in Australia before we move to a complete lockdown like New Zealand?
So I know Brendan, and I really respect his opinion, and as I suspect many of the other voices that are giving opinions right now, I would say that the main feedback we're getting from the public and indeed the healthcare professions at the moment is confusion and unclear messages. So I would be very happy to talk to Brendan one-on-one. I really would like him and others that are coming out without all of the information that should and could be available to them and making their opinions. It's not helpful. In terms of a lockdown, I've talked about that before. There is a range of opinions about when we should do things and how much we should do right now. What is not what is agreed by everybody are the things that we should do them and why we should do them. And why should we do them? It's because this is an infectious disease, it's spread from person to person, it's spread by close contact, so it's social isolation. And particularly, my main message today, hopefully it's getting through, if you're sick, stay at home. This is in our hands, and we need to take this seriously, otherwise there may well be further measures that will have to be introduced along the lines of what Brendan has said, Brendan Crabb that is, but I really would hope that people will take these messages seriously, and so we can stop the spread of this infection, flatten the curve, make sure we have enough health care for all of us when we need it over the coming weeks and months.